Hello, my name is Neil Lagali. I'm at the Department of Ophthalmology at Linköping University in Sweden. And it's really my pleasure to talk to you today. And I would like to thank the organizers for giving me the opportunity to present to you today. I'll be talking about the cornea in aniridia specifically, and what we've learned from our various cohort studies across Europe. So the cornea in aniridia experiences a progressive loss of transparency over time, and this is known as aniridia-associated keratopathy, or AAK. It's a major cause of vision loss in aniridia, and it can also be associated with much pain and discomfort. Now, we know that in aniridia, there can be development of cataract and glaucoma. However, these conditions are treatable. Also, we know that the foveal hypoplasia is quite prevalent, but this is non-blinding and it is stable over time. So, by contrast, AAK can be blinding, and it's the main reason for poor visual acuity and blindness in adults with aniridia. And it's not stable over time, so it is progresses with age. There are several difficulties concerning AAK. First of all, the genetic heterogeneity. I will be talking a little bit more about that later, but this is basically the fact that we have many different mutations in PAX6, and this can lead to a wide variability in the phenotype, and also the onset and the rate of progression of the keratopathy. Also, AAK is bilateral, affecting also the limbal stem cells in both eyes. So many of the treatments that are normally applied for limbal stem cell deficiency rely on one healthy eye as a donor site. However, that cannot be done in aniridia, so there are very limited treatment options for AAK. Also, AAK can be slow progressing over decades. So this also has implications for treatment, when to start treatment, how long to give treatment. When we talk about AAK, we like to talk about the severity and try to quantify the severity. So we have a keratopathy grading scale that we use, that we've developed. This grading scale is based on the outwardly visible by slit lamp microscopy, the conjunctivalization of the ocular surface. And this is sort of the hallmark sign of AAK. However, this scale is different from the general limbal stem cell deficiency scale because here, specific to AAK, we distinguish an early breakdown of the limbal barrier in grade 1. Also, different from the general limbal stem cell deficiency case, in AAK, we see a progression of the keratopathy that's generally symmetric radially. So we don't see a single sector or multiple sectoral involvement of the cornea in AAK, but what we tend to see instead is the radial symmetry of this conjunctival tissue growing in towards the center of the cornea. So if we look at the scale here, we can see that in grade 0, it's a very well-defined, nice limbal border. And this was an image taken from both sides of the same eye in a child. There's no encroachment of the blood vessels or the white conjunctival tissue into the clear cornea. When we go to grade 1, this is now where we first see the signs in the slit lamp of the conjunctival invasion. And this is confined to the limbal region. It's about within 1 millimeter from the limbus. But it requires a careful slit lamp examination to detect this early stage. In many cases, it's missed. And this is often occurring also in childhood. But when it progresses, we can see that in grade 2, for example, this tissue has now started to enter the periphery, and this is again circumferential. And this is grade 2 AAK, but it doesn't affect the center of the cornea. In grade 3, that conjunctival tissue with vessels has now grown over the entire cornea. And in grade 4, which is the end stage, this is a thick white pannus that now covers the cornea, which is vascularized. And so that's the most severe stage. But when is the first onset of AAK? Well, we've looked at this in various cohorts of subjects around Europe, and I can show some of the data here. For example, in the left-hand graph, we see here in a Polish cohort of subjects, and we looked at 67 eyes in this case, we can see that the AAK grade increases. It's typically grade 1. It was typically grade 1 in children, but once reaching adulthood, this jumps to grade 2, and then it slowly progresses over time. In the German cohort, the graph on the right here, with 86 eyes, we saw that children had anywhere from a grade 0 to grade 2 AAK, and this tended to progress again, typically after the age of 20, where we finally get progression to the grade 3, which is a central corneal involvement. But this illustrates also that there can be quite a bit of variability from person to person. And what is really the source of that variability? Well, genetics plays a large role in this. Why? Well, because in the PAX6 gene, there have been over 500 unique mutations reported that are leading to the aniridia phenotype. So the exact type and location of the mutation can strongly impact the phenotype, can also impact the progression and severity of AAK and the prognosis. The degree of PAX6 involvement also can be correlated with the severity. So if it's just a small point mutation or missense mutation, it could be of a limited consequence. However, if it's certain types of mutations in one or even more exons, multiple exons, then it can be more severe, and even whole gene deletions can be the most severe. These graphs illustrate the importance of where the mutation is located. In the left-hand graph, these subjects, 60 eyes, had mutation or deletion in the PAX6 coding regions of the gene that were coding for the PAX6 protein. Here we can see that the AAK grade is gradually increasing with age. And the graph on the right, however, these are 10 eyes with non-coding mutations. So those are mutations in regions that are not coding for the PAX6 protein. And these can be regulatory regions or in the flanking genes, such as ELP4 and DCDC1. And what we see here is that the keratopathy is limited to a grade 0 or 1, and it doesn't progress past this. Not only that, the visual acuity is better in these cases. For example, a 0.5 logMAR acuity in these cases compared to 1.25 in the PAX6 mutation cases. So to summarize this, we have done, based on our studies, we can look at the following table where we list on the left-hand side the mutation type, and then we look at if it's progressive or not and what the increase in the AAK grade is. So if you're looking at the non-coding mutations, they have about a 10% prevalence, and the phenotype is very mild and it's non-progressive. Missense mutations, also similar prevalence, also mild cases, but there is about a 1 grade increase over the non-coding cases. Now, the bulk of the mutations in PAX6 and aniridia are the premature termination codon or C-terminal extension mutations. And these are like the run-on or the frame shift mutations. And they are nonsense-mediated decay-inducing mutations. So these are not producing, there's a lack of the functional protein. And this is most prevalent, about 70% of cases. It gives the classical progressive picture of AAK, and the grade is about 1 to 2 increase over the non-coding cases. And again, as mentioned earlier, if it's multiple exons involved, these tend to also give a more severe phenotype. Finally, the chromosomal deletions at about 10% of cases. Now, these involve gene deletion, so the entire PAX6 gene, as well as other genes such as the Wilms tumor, ELP4, and so forth. These tend to give the most severe phenotype already at a young age, and the AAK grade increase is 2 to 3 grade increase over the non-coding cases. And the classical example of this with chromosomal deletions is the Wagner syndrome. So what have we learned then from our cohort studies? Well, the classic aniridia progressive phenotype associated with the premature termination codon mutations are giving the conjunctivalization of the ocular surface, and this is very much linked to the limbal stem cell insufficiency. However, besides this classic picture, we've come to a realization that there are many other features at the ocular surface that are impacting AAK and that are coexisting with the keratopathy. For example, tear film abnormalities. So this is abnormalities not only in the production of the tear film, but the quality of the tear film and also the content of the tears. We tend to see higher level of pro-inflammatory and pro-angiogenic cytokines in the tears and lower levels of anti-inflammatory factors. Meibomian gland dysfunction is also prevalent in aniridia, and this has been found in several studies. It's also important to realize that there's a chronic inflammation of the ocular surface in AAK. Also a neurotrophic deficit, and the inflammation and the neurotrophic deficit can already occur from a very young age, even when the cornea is clear and does not appear to have AAK. The neurotrophic deficit is important because the nerves in the cornea are needed, a certain nerve density is needed to ensure proper survival and differentiation of corneal epithelial cells. And also the nerves in the cornea help to keep it avascular, to keep the vessels from growing into the cornea. So we also see an ocular surface damage and dry eye signs in aniridia. And this is seen with the ocular surface staining, also the reduced breakup time and reduced tear production. And it's interesting that these parameters are already altered from about 10 years of age, and that is across the board, regardless of the type of mutation. So what we can think about with a chronically inflamed dry ocular surface with this nerve deficit, well, this is set up so that the keratopathy will progress, and it usually leads to failed attempts at transplantation and rejection, as well as failed limbal stem cell transplantation. Also, what we've learned is that genetic testing is very important, just because the genotype can have a large impact on the progression of the keratopathy and the prognosis. So now thinking about treatment, what are the possibilities for future treatment of AAK? It's interesting that the limbal niche is believed to develop fully only postnatally. So only after birth, the limbal niche really completely develops after eyelid opening. And this may explain why the keratopathy in aniridia has a delayed onset. And the limbus is likely very sensitive to the dosage of PAX6 protein. And also, it's been postulated that the stem cells may actually not be absent in aniridia, but they may be dysfunctional, or they may, over time, lose their proper function. So this all means that there could be a potential treatment window at a young age where we could affect the limbal stem cell niche to perhaps slow or prevent development of AAK. So some of the treatment possibilities could be to address the protein, PAX6 protein deficiency, for example, using a small molecule type approach, which you will hear in other talks here at the conference. And really the advantage of this small molecule approach to increase the production of PAX6 is that it can be applied to all mutation types. Another approach is addressing the main types of mutations in aniridia, which is the premature stop codon, which occurs in about 70% of cases. And here is the classic example is the atalurin. And it's interesting that perhaps in the future, Adaluren eye drops could be developed. Also, as I mentioned before, the nerve deficit is very important, and this is something that could possibly be addressed through providing neurotrophic factors exogenously. So, for example, using autologous serum eye drops or Cenegermin, which is a newly approved drug, which is nerve growth factor. Also, we should be trying to address the neovascularization, and this could be done with anti-angiogenic therapy. And there's a wide variety of therapies available, and they are approved for use in the eye, but not necessarily in the cornea. So these could be used off-label. Finally, we could think about in the future addressing the limbal stem cell insufficiency, perhaps even by using something like lentiviral gene therapy to deliver a fully functional copy of the PAX6 gene, specifically where it's needed in the limbus. So, but these treatment possibilities are not without issues. There still needs to be issues to resolve and more research to be done. In particular, when do we start the therapy in terms of trying to slow down or prevent the development of AAK? It should be perhaps quite early in life. We don't know if we can reverse already progressing AAK. Also, because AAK is developing and progressing over a long time period, what would be the duration of the therapy? How long could it be given? And how long will it last? Also, we don't know very much about dosing, and also study endpoints are very important to identify because these are the endpoints that we will try to quantify to see if the therapy is actually working. And this could be in, for example, in groups such as infants. And finally, I wanted to emphasize that randomized clinical trials are needed with multiple centers because aniridia is a rare disease. We need to have a critical mass of patients in order to run proper randomized trials. And we should also try to strive for as homogeneous groups as possible in terms of genetic status, mutation, age, degree of keratopathy, and so forth. Also, we should prepare for long follow-ups in randomized trials because, as I mentioned, AAK can develop over decades, and this is typically not the time frame that randomized trials are conducted, but it's something that needs to be looked at. So with that, I will conclude the talk, and I would like to acknowledge contributions from many of my collaborators in Sweden, but also Norway, Poland, and Germany. And also would like to acknowledge funding from associations such as Aniridia Norway, as well as the EU Cost Action Aniridia Net. Thank you very much.